The information presented in this podcast is for educational purposes only and is not meant to be a substitute for clinical mental health treatment. If you or someone you know is experiencing a mental health crisis, please dial 988 or head to your nearest emergency room.
Welcome back to another episode of the Black People Die by Suicide 2 podcast. It's Takia here, and before we get into this week's topic, y'all, things have been happening, and we just got to keep it real with y'all. So for this episode, things are a little bit different. When Jordan and I recorded this interview back in May, we were in the process of recording this and getting ready to head to the airport. So with that, we did not get a chance to record the second half of the episode, which has the community change maker, the spotlight, the oh my God segment, self-care, moment of inspiration, all that good stuff. And at this time, Jordan has taken some time away from the organization to focus on her health. And I will also be taking a little bit of time away to practice self-care because we cannot preach self-care and not do it ourselves. And so the organization is taking off and things are great. However, it has been a lot. And so we never got a chance to actually record the second half once we got back from traveling. And a lot has been happening personally as well as within the organization. We're going through some changes as well. And honestly, it has been a lot to manage. We're definitely going to have a heart-to-heart with y'all on an upcoming episode. So this particular episode is shorter, and on future episodes, probably the next 1 to 2 episodes, we will have a guest co-host with me and another person. As I mentioned, Jordan has taken time to step away. I'm getting ready to go on vacation, y'all, because I need it. And also, we just want to thank y'all for continuing to support the podcast, but also just supporting us as an organization. We have a lot of great things that are in the works, so stay tuned, especially if you are in the DC area. But even if you're not, we actually have something coming up virtually as well. So y'all know September is our time. It's our month to shine. We will be taking some time to pull back a little bit in July as well as August so that we can really shine during our month in September, which is Suicide Prevention Awareness Month. So thank you all again so much for listening. Y'all, please bear with us as we go through these organizational changes and life-and at the same time. So this episode is a little under 40 minutes, and please forgive us for not having the second half, but we still wanted to make sure that we got an episode out to y'all so that we can stay consistent with our bi-weekly schedule. Again, thank you for supporting us, and you all have an amazing week. Oh, I forgot to add, if you are watching this episode on YouTube, I look tired as I don't know what. On the day of that recording, I believe I was going on 2 or either 3 days of little to no sleep, and it was catching up with me, and I could see how tired I looked in my eyes. And so I just want to let y'all know, don't come for me in the comments, and I am not high, I am not on any sort of substances. I was just tired. But y'all go ahead and y'all watch it and y'all enjoy this episode. But y'all know we always keep it real on Black People Die by Suicide too. And I just got to let y'all know your girl was tired that day, okay?
Welcome to the Black People Die by Suicide 2 podcast, where we discuss all things mental health with an emphasis on suicide in the Black community. I'm your co-host, Jordan.
And I am your co-host, Takia.
If this is your first time tuning in, welcome to our space. If you're coming back for a subsequent episode, we thank you for your continued support. So, as usual, when we first log on or we first get into these episodes, we do a check in and we want to encourage people to really talk about how they're feeling. Because too often we say that we're fine and we're good just out of politeness, but that's not really how we feel on the inside. Today, I'm really excited. It's a busy day for us. Taki and I are doing some traveling this weekend for the organization. So trying to get packed up and we're going to get an award this weekend. By the time you all see this episode, it would have already happened. So a lot of exciting things are happening, which I'm really, really grateful for. Takia, how are you doing today?
Checking in, and we have to do our PF because we said that we will
Oh,
always
yeah.
include our psychological fortitude. Shout out to Dr. Rita Walker, or the esteemed Dr. Rita Walker, right? How am I feeling? I'm feeling a little discombobulated. I am feeling a little all over the place because there's just so much happening, and the organization is just taking off faster than I think we could have ever imagined. So I'm trying to keep up with, as we call it, the baby, the child. The baby is just running really fast, like a toddler. And I'm just like, oh my gosh, how do I keep up? Yes, and also tired as well. So that is how I'm feeling. If I had to rate my psychological fortitude, um, I'm going to give it a solid. I'm going to give it a 5. I know it's best to be what Dr. Walker said, at least the 8, right?
Yeah.
Yeah, well, I got some work to do, but that's where I am. And for if there are any new listeners, Jordan, you may want to explain to them what psychological fortitude is.
Yes, so psychological fortitude, concept by Dr. Rita Walker, of course, is your ability to sort of bounce back and be resilient in the face of all of the stressors that we encounter from day to day. And so she encourages you to give yourself a rating from 0 to 10, with 0 being, I just cannot do this right now, and 10 being, I'm functioning at my highest level of self, things are going well. So I'm probably in the middle too. I would say a 5. Which is actually pretty good for me these days. I'm not mad at it. I'll take a 5. Yeah, she encourages you to be at an 8 or above, but your psychological fortitude will vary from day to day. So that's where we're at today. And
Jordan, can
go
I
ahead.
add something? So I would
Absolutely.
add too, and it's helpful to know your psychological fortitude because that also helps you to determine what you have the capacity or the bandwidth for. Because we can be at a 5 and we'll still do things for other people, like, oh, I can do that, knowing that. So it's to help you also to have a level of self-awareness and to be honest with yourself, but then also realizing if you're at an 8 or below, technically it's probably best not to do anything for anyone else until you are there. So I just wanted to add that.
Thank you, Takia. Today we are joined by Dr. Durga Roy. She is an associate professor of psychiatry and behavioral sciences at Johns Hopkins University School of Medicine and the medical director of the Johns Hopkins Neuropsychiatric and Brain Injury Clinic and Head Injury Outpatient Psychiatric Day Program. She's also the director of education for the Johns Hopkins Psychiatry Internship and the director for the Consult-Liaison Psychiatry Fellowship at Johns Hopkins University School of Medicine. She is a board certified in general adult psychiatry and consult liaison psychiatry and behavioral neurology and neuropsychiatry. She has authored numerous peer reviewed publications focused on neuropsychiatric outcomes after traumatic brain injury. Her area of research interest focuses on the neurobiology of depression after traumatic brain injury and the study of prognosis markers for depressive symptoms after traumatic brain injury using resting state functional neuroimaging techniques. And Dr. Roy will get into what all that means. It's super exciting work. Dr. Roy, how are you doing today?
Thank you, Jordan. Thank you, Takia. And I'm so honored to be here. I'm feeling blessed today. I had a very long week and it was very busy, but extremely rewarding. So every day that I get up and I do what I'm doing, I'm having fun. I love what I'm doing. And at the end of the day, when I'm winding down, I feel a sense of reward. So I'm doing well. Thank you.
Great. All right. So, as you all could probably guess for the topic, based on Dr. Roy's biography, we're going to talk about the connection between brain injuries and mental health. Prior to us starting this episode, I was telling Dr. Roy that I had never actually considered that brain injuries would affect someone as far as their mental health. I understood that it may cause impact to like your memory and your cognition, maybe your motor skills, things like that. But it never dawned on me that it would also affect your mental health, which makes sense because it's the brain, right? So, Dr. Roy, if you could just tell us a little bit about yourself and what you're doing at Johns Hopkins here in Baltimore, Maryland. We have to shout out Baltimore.
Yes, happy to. And yes, I have to give a shout out to Baltimore. I love working there. I love working with my patients there. So as you started to describe, I run the Neuropsychiatry Clinic, and that's a clinic where we see people who have had some kind of injury to the brain. Now, it could be traumatic brain injury, which is my specific area of focus, but really brain injury is anything that kind of affects the structure of the brain. So it could be strokes, seizures, tumors, those kinds of disorders. Typically what happens is people come to our clinic after having one of these neurological insults, and then they start to feel different. They start to experience depression. They start to experience anxiety. Sometimes they have a lot of mood problems. They have behavior problems. Cognition is definitely part of it. It's a big part of what happens after brain injury, but we work very closely with another department in neuropsychology to help with that aspect. So I primarily treat patients when they have psychiatric disorders that may occur after a brain injury. A lot of my research focuses on what is the mechanism that's happening in the brain. So, for example, if somebody did not have a brain injury before, they had no psychiatric problems before, they get hit in the head, then they develop depression. What's going on mechanistically in the brain that might be associated with those symptoms, or what's kind of going on from a social or psychosocial perspective in their lives that's causing that.
This is fascinating. I'm
Yeah, I'm
excited
like,
about this episode.
yes, I am. Just because this is not something we've ever talked about, so I feel like it's something that needs to be a part of the conversation. And I don't know if you agree, Dr. Roy, if it's often overlooked.
100%. So there's two aspects of it. There's first the aspect of traumatic brain injury in general, TBI in general, which is overlooked by medical providers. So many times patients come to me and my colleagues because they have had some level of, let's say they had a concussion, they were taken to the ER. They're very high functioning, run their own business, able to balance their own checkbooks, really doing well off. Have a concussion, go to the ER. The doctors say, that's a mild concussion. You probably lost consciousness for a couple minutes. You can go home and move on with the rest of your life. But the symptoms that evolve, the months that follow that injury can be really, really debilitating. And oftentimes we're finding that a lot of these patients are being told by doctors, just rest it off. It's a concussion. You'll get better. Don't worry about it. There's nothing medically we need to do at this time. And their symptoms aren't really taken seriously, in particular when those symptoms last a very long period of time, 6 months, 12 months out. Typically speaking, with concussions, the average time to recover is like 10 days, but there's a measurable minority of people who persist with post-concussive symptoms, with depressive symptoms, at least 6 to 12 months out. And these are the people that we're seeing. So it's very often overlooked, number one, in the medical provider community. So the medical community, you really have to be looking out for this as a clinician. The second group of people in which it's overlooked is minorities. And so oftentimes Latinos and African American communities are really, first of all, having very limited access to care. So they're not getting seen early on. And then when there's a psychiatric disorder, depression that develops, or some mental health condition sort of ensues after that, they're not able to get the access to care. There's also there's very high rates of TBIs, for traumatic brain injuries, that happen in minority populations. Oftentimes in urban communities, if there's assaults that are occurring, or if there are, recently a study that was just done that TBIs from firearms can be very high in these populations. So two kind of ways to see that this is a very vulnerable population that is often overlooked.
And for our listeners and viewers, can you define what a traumatic brain injury is in case anyone doesn't know?
Absolutely. So the best place is to always start with the definition. So there are various classification systems that have different things that they describe as what determines a traumatic brain injury. But really, and there's no consensus. So there's like the CDC, the WHO, BADOD. There are various places that have these criteria, and no one 100% agrees with overlap. But one thing that most people do agree on is that it has to be some kind of trauma to the head. So it's coming from the outside. So it can be hitting the skull from either side that causes some kind of physiologic disruption of brain function. And what that means is the patient is reporting one of three symptoms, or all three symptoms. Loss of consciousness. So this is where we ask patients, did you black out? Altered mental status. This is where we ask patients, were you dazed, disoriented, or confused? And post-traumatic amnesia. This is where we ask patients, do you remember what happened before or after the injuries? Now, there may or may not be kind of neurological signs, so you may not see sort of evidence of actual injury in terms of weakness or deficits in the facial structures, or their imaging may be normal. So their CT scans or their MRI might be normal. But really those three symptoms of asking, did you black out? Were you dazed, disoriented, or confused? Or did you forget anything before or after the injury? If there are signs of that present, then that's what we say was a traumatic brain injury after it happened with a trauma to the head.
Do you find that there are any specific disorders that someone may be more likely to get if they receive a TBI? Like, are you seeing more depression? Are you seeing schizophrenia? What are you seeing out there when you're talking to your patients?
So this has been, and this is my exact area of research, so I can speak both from the perspective of what I see day to day in my patients and also what's out there in the literature. So it's very well established that the most common complication and sequelae after TBI is depression across the board. All studies have shown that depression after TBI is the most common. Then there's the cognitive aspect as well. Major depressive disorder is what we most often see. It's important to ask ourselves whether somebody had some kind of psychiatric symptoms before the TBI, because people who have had a history of depression, have a history of bipolar disorder, have a history of any kind of psychiatric illness, they are at higher risk of developing depression later on after a TBI. But typically speaking, depression is the most common and very difficult to treat because it doesn't necessarily respond to the same it doesn't respond to medications the same way that someone with, let's say, major depression without a TBI might respond.
Wow. Okay. I'm glad you mentioned that. I was wondering if there was a difference between the way you would treat someone who just has depression that doesn't have like that underlying cause, or if you had to do like a different treatment modality if someone does have, I guess, the comorbidity of having the TBI and now developed a mental health disorder. So I'm guessing sounds like there's a difference if you can't quite do medication the same way.
Right. It depends. So it always depends on the patient, and we don't know what their brain looked like before the brain injury, right? What we do see is that, firstly, this population is very, very susceptible to side effects. So we have to start low and go very slow from that perspective. The second piece of it is that, what we do see often is that even at good doses of medications, patients with a TBI may not be responding as well, just because their wiring is now different than someone that doesn't have a brain injury and has major depression. it really, again, depends on the patients. I've seen patients get better, of course, but then we always have to think about there is a different structure in the brain now, or different circuitry that might have been affected, which is exactly why I wanted to research this population. The other thing is, and this is a big thing we do at Hopkins and a very unique approach to our framework in psychiatry, is we always operate around the framework of the perspectives model, which is everything doesn't always chalk up to a disease, right? So it's not always that there's something broken in the brain, but we ask ourselves, is this something that the patient has encountered in their life that's is explaining their presentation? So their life story. Is this something about who they are as a person? So their personality, their temperament, their cognition at baseline. Is this something that the patient does? Are there behavioral aspects that kind of play into it? So we don't always jump to just medications when we're treating these patients. It's important to kind of look at the whole picture. Psychotherapy, which is very, very critical, as you all very well know, is a big part of it, kind of rescripting the narrative, getting in there and providing that psychotherapeutic alliance with the patient from the therapist, from the psychiatrist, looking at their personality, looking at their behavior. These are all ways that we're, combining with medications to treat these patients. So it's not just the medications that we may or may not say work or don't work.
I'm interested in knowing, as you were talking, and you talked about it a little bit, the timeline from when someone would come to you, because I would think typically people would just go to their PCP. So how long before someone's like, okay, I need something else because I'm still having these symptoms?
Great point. So generally what happens with a mild TBI, so a mild TBI is basically a concussion, and that's where people have a very brief loss of consciousness. They're out in the field playing football, for example, they black out, then they get back and they start playing again. Typically, if people have symptoms like headaches, dizziness, and they're not bearable, then they go right to the emergency room or they go right to the doctor. It's really those symptoms that happen months after. So the literature really supports the fact that majority of people may recover in the first, 10 days to 2 weeks after a hit to the head. If it's a mild injury, if it's severe, you're in the hospital, you're in the ICUs. If it's a moderate or severe, if you have a brain bleed. So that's a different kind of question there. But when they have post-concussive symptoms, oftentimes they emerge and then they kind of get better. It's when they persist in the 6-month mark and longer, then we want to be concerned about it and it's a problematic thing. This is where you start to see kind of 6 months worth of ringing in the ears, headaches, dizziness, depression, insomnia, appetite changes, those kinds of things. So really, we're seeing people in our clinic anywhere from 6 to 12 months after their injury, because that's around the time where they're saying, I should have gotten better by now and things aren't better. Can you take a look at this?
Have you noticed any connection between having a TBI and experiencing like suicidal ideation or suicidal behavior? I would assume there might be a link between those two if it is causing people to suffer with their mental health.
Yeah, so it's par and par for the course. It's really part of that depression syndrome, right? So that's the thing that's going to be the most serious and the most sort of the thing that we're going to think about the most in terms of consequences after a TBI that could end up ending a patient's life. The rates of suicide are in the general population, anywhere from 10 to 20%. With TBI, it's much higher. So it's about 30%, 40% if after you've had a TBI. So again, depression being the most common, higher suicide rates in people who have had TBI. And why is that? So it's a couple of reasons. Again, not back to just disease. It could be that parts of their brain now have neurochemically changed, neuroanatomically changed. The neurocircuitry is different. But they're also asking themselves, I'm not the person that I was before my brain injury, right? I'm not doing the job that I used to do. I can't balance a checkbook anymore. I can't make a grilled cheese sandwich. These are all things that are very different. So that can lead to a lot of demoralization when we think about that life story aspect. And so something we really are on the lookout for and extremely diligent about asking at every visit.
I'm wondering, in terms of support, if there's someone listening or that maybe have a family member who's struggling with this, or maybe they themselves are struggling, just thinking in terms of what would be some things you would share with them from, I guess, both aspects. So maybe it's like a two-part question. How does one support a individual or a family member, friend who's has experienced a TBI, with their challenges as it relates to their mental health as well?
Yeah. So I would say that this is what we refer to as caregiver burden and caregiver burnout. When we have family members coming in with a loved one who's really frankly not the same person, and they've essentially had to uproot and change their whole lives to take care of this person. So the first thing is you're doing a wonderful job supporting your loved one. I mean, that's what we always want to make sure everybody's hearing, because the patient that's affected really needs all the support they can have. They need all the unconditional love they can have and get, and understanding that what they're doing is not their fault, right? Their brain is in a different place now. It's also important to know that, specific communities that are underserved have lots of barriers and access to mental health care. And therefore that burdens the caregiver to say, well, what do I do? I don't know how to, get my loved one treated. And so getting access to care and trying to find resources is really important. We have a lot of advocacy groups here in Maryland. The biggest one is the Brain Injury Association of Maryland, is a really large consortium of patients and providers in this area, and work with NAMI as well, kind of combined to promote mental health in people in this particular population. But for people with a friend or a loved one, really being there for them, understanding that their symptoms are really out of their control, and getting as back to normal of life that they can is a large challenge, but something that we have to expect may not necessarily happen. And I always tell my patients, I may not be able to get you back to who you were before your brain injury, but I can certainly get you better than you are today and now. So kind of working along that line and focusing a lot on their wellness and their ability instead of disability.
Oh, I'm so glad you brought that up. A lot of times we talk about mental illness, but people forget that mental wellness exists. Like, it's a thing. When we don't take care of our mental health, sometimes that's what leads to mental illness. But sometimes, maybe not all the time, but I'm so glad you said that, because when you talk about mental wellness, that instills hope. That speaks to recovery, that things can get better, that things do get better. So I'm really glad that you brought that up.
Thank you. That's our HOPES program, which is the Head Injury Outpatient Psychiatric Enhanced Services. That is one of our mottos, which is that we are all about wellness and ability and not disability. Sort of cater to your strengths. What are you able to do now going forward? Let's not focus on what you can do. And your emotional well-being. What are things you're doing today to keep yourself well?
I did want to ask you if there was any research out there that focuses on TBI and mental health for kids specifically. And I asked that because a lot of kids play contact sports, especially in the Black community. A lot of our boys play football, basketball, like, different physical sports that may potentially lead to an injury or a concussion. I played softball. I've been hit in the head with a ball before a couple of times, and I lost consciousness. So if you could speak to that, and I guess for any parents who may have concerns because their child has experienced this, what should they look out for that would give them a clue that they might want to have their kid assessed further?
Great question. So I'm going to have to preface this with a disclaimer that I'm not a child psychiatrist or a pediatrician. And I definitely, my work focuses mostly on 18 and above. But I can touch around some of the literature because I have spoken about it before. So first of all, if you look at the age spectrum, the people that have the most amount of head injuries are the little ones and people above 65. So if you look at the spectrum of age, those are the most vulnerable populations. From the younger side, we're seeing not just concussions from sports, but we're seeing, kids are climbing trees or, they're, riding their bikes and sometimes without a helmet. So there's a lot of activity they're doing anyway that's putting them at risk for hits to the head. Typically speaking, you look at the research on the trajectories of concussive symptoms after children who are in sports, and really, and I have coined this phrase, that there's nothing mild about mild TBI or a concussion. There's nothing mild about mild traumatic brain injury, because sometimes those symptoms even in youth can continue to kind of persist over several months. Again, just like the regular population, there is a chance that they can recover very early on. One thing that we do know from some of the studies that were done a few years back is that within schools, it may often not be reported as often. So students who are doing team sports through the schools or through leagues may not be reporting those injuries as often to their coaches, or the staff or personnel at the school may not be kind of addressing them right in real time. So that is one thing to think about. Contact sports, of course, you're always going to have the highest risk. So we're talking football, lacrosse, soccer, these kinds of things, hockey.
I know you touched a little bit earlier about, I guess, barriers to treatment for people that have traumatic brain injuries. Can you talk a little bit more about what those barriers are? And if there's anything in place to kind of help remove those barriers so that people can have access to treatment?
Yeah, no, it's a great point. And this is something I'm very passionate about, which is why I was very honored to come and talk today to you all about this as well. Because it's, first of all, it's the bottom line is it's access to care, right? It's access to good quality health care that is not afforded to many, many communities and needs to be afforded to many communities. There's a lot of literature that shows that the health disparities within the TBI population is quite profound, to the point that there are people who may have had a severe brain injury, and when they are admitted to the ICU, they don't follow up. They don't get follow up afterwards. They don't get to see a psychiatrist. They don't get to see, a primary care doctor or a neurologist if they have seizures, let's say. And so really access to care is the big, big issue. And then, compliance with care. So like, let's say, you have people who are disadvantaged, who are not able to kind of be able to be seen frequently in clinics. So there's transportation issues, there's financial issues, I have to take care of my 80-year-old mom at home, and I can't leave her because I don't have anyone else to take care of her. Plus I have to work, types of issues. So it's really the access to care. And when there is very limited access, it's getting to their appointments. It's really participating and engaging in care. So access and engagement, I would say.
I wanted to ask, as it relates to, because you mentioned barriers, I'm wondering, and would assume yes, but maybe you can speak to that. I know mental health, of course, the stigma wise, but do you feel like, do people, I guess, experience maybe shame, like as it relates to their TBI? Yeah, it just kind of got me thinking, because if you don't remember who you were before, or remember what happened, and then maybe trying to figure that out, and it's like rediscovering yourself. So I'm wondering, like, what type of emotions come with that, and I would think shame may be one of them.
That's a great point. It's a lot of, so the word that I used earlier is one that captures how somebody feels when they've lost functioning or they've lost something, which is demoralization. So there's a lot of
Mm.
demoralized experience that people feel. There is the sense of a stigma. So you think about TBI, you think about psychiatric disease or symptoms. It's a triple threat, because combined
Mhm.
together causes a lot of disability. This is somebody who may blurt out something embarrassing at the dinner table, with a family member. This is someone who may not be able to do their job like they were able to do, or even work anymore, and now they're on disability. This may be somebody who is not able to kind of get up and go to the bathroom and remember where things are, in their house. So there's a sense of demoralization, especially if there's an awareness that I used to be able to do these things and I can't now. And then there's that stigma. The word stigma kind of it's a very heavy term, and we have to kind of be thoughtful about how we use that. But, kind of not wanting to share their story about their TBI with their peers, because fear that no one's going to really get what I've gone through yet. So it's different to have depression, because maybe other people could have depression and maybe they've had some similar symptoms. But to say that, you got hit in the head and you can't remember anything, you can't remember what you had for breakfast yesterday, there's a big piece of shame that I think comes with that. Absolutely.
So if there's anyone listening or watching who's in the DMV and a lot of what you've said has resonated with them and they're interested in perhaps pursuing some treatment with Johns Hopkins, how can people get in touch with your clinic? And I guess what's a good place for them to start if they do want to seek services?
Yes, great question. So our clinic is based at Bayview, and the model is that you see a psychiatrist. So you see me and some other colleagues that see patients with brain injury for medication management. But you have the criteria is you have to work with a therapist, because we really believe that it's a team-based approach, that therapy and medication management together are effective. And then our brain injury day program is an option for people who want a lot of structure during their day. So in addition to those two things, you would come several days a week. You would be able to work on mindfulness, on anger management, working on education about your brain injury, family psychotherapy, all these kinds of things. So on the Johns Hopkins website, if you just Google Johns Hopkins Neuropsychiatry Clinic, all the information will pop up right there. And we've tried to make the landing page pretty easy to navigate, that you can just contact the number there.
You know what? As you were talking, for people who are listening, I would actually, as we often talk about how there needs to be more Black people or just people of color of general in the field pursuing what you're doing, I would encourage people to look into that. I know there's a shortage of therapists. I do know that, but you're like the only person that I know that's a psychiatrist that focuses on like TBI. Anyone else that I know, like I don't really know anyone else.
There's not that many of us. There's very few neuropsychiatrists, in the country, and definitely in the area. There's only a handful of us. So I 100% echo what you just said. I think we need more people to be interested in this area, to do research in this area, and to see patients in this area. And that would be really great if we could have people from various backgrounds to kind of contribute to this field.
And if we do have any clinicians or psychiatrists who are listening, is there like a certain track if they wanted to shift over to something like this or learn more about TBI? I don't know exactly how that would work.
Yeah, so the education sort of structure is that you do 4 years of psychiatry residency training, and then there's a fellowship in neuropsychiatry that people can do after training. But many neuropsychiatrists have just done this based on clinical practice and seeing patients with TBI, and said, I've seen enough patients with brain injury, and and we give a lot of education on this. We give lots of talks at Hopkins around the country on this topic exactly, to educate other psychiatrists on how to treat TBI. But absolutely, I mean, we're happy to connect people, clinicians with patients, with education on this area, both from a treatment perspective as well as from a patient advocacy perspective.
I think I speak for both Takia, both of us, that we're so grateful that you joined us to talk about this. And I really feel like this episode is going to help a lot of people. Is there anything that you want to add or you want people to know about traumatic brain injuries in relation to mental health and what you do? Any tips, advice, anything you'd like to say?
My biggest advice is early intervention. So if you notice something, see a physician, get referred, and come and see us or any neuropsychiatrist in the area that's available. If there's there are openings, definitely get on top of it early rather than later, because preventative care is always the best care. And I am very passionate about this topic. And if there's any other platforms for me to kind of disseminate this message, I would love to, because so the more we can pass on the message that this is an important thing to look out for, that would be great for the community.
Yes, thank you so much. I'm actually I've been so shocked and so like my processing all of this. I'm usually the talkative one on the podcast. My mind is just like, so Jordan has been leading, but wow, I'm just like, wow. Yeah, I am definitely I'm taking it all in.
I'm sure our audience and our viewers are probably like, oh my gosh, Jordan's really like Oprah Winfrey right now with the interviewing. But this was so exciting to me. again, prior to us starting the episode, I was chatting with Dr. Roy a bit, and I was telling her that I really didn't, it never dawned on me that this was a thing. And the more I read about what she does and what Hopkins is doing, like, I found this so fascinating. So I had lots of questions. And I'm so excited that you were able to join us and talk about this,
Yes.
because I do think this is going to help a lot of people in our
Mhm.
community.
Yes, thank you so much. I know it's been in the making for a while. It seemed like it took a long time for it to happen, but
That's
I'm
all
so
me.
glad.
That's all my fault.
No,
Sorry.
no. That's okay. I'm really excited, and I'm so glad that we had you here, because now this gives me and my entrepreneurial brain, no, just thinking of more ideas how we can include this in the conversation, not just in the podcast, whether that's workshops, different events that we can do to make sure that this element is added to the conversation. Part of the reason why we specifically focus on suicide prevention, or just whether it's intervention, post-vision, as it relates to the mental health conversation, because people like to shy away from suicide. They just want to say mental health. And we're like, you can't omit suicide from the mental health conversation. It doesn't work that way. And so as you were talking, it had me kind of thinking about, okay, so what is it that we can do to make sure that the TBI is also included in the conversation too?
Mm-hmm. Mm-hmm. And making sure that the clinicians, and this is my job, is to make sure doctors are asking everyone. It doesn't matter what they're coming in for. If they're coming in for anxiety, for headache, whatever. Did you ever have a brain injury? Did you ever get hit in the head? That's part of a normal psychiatric evaluation. So,
Well, we thank you
yes.
so much for your time. Thank you for
Thank
joining us. Thank you for
you.
coming to give us all your knowledge. And we really appreciate that we were able to do this. And again, thank you so much for what you're doing. Not just for the people here in Baltimore or in the DMV who come to see you, but even just using your voice to talk about this and raise awareness for it. Just thank you for all the work that you're doing.